and we've got to make sure that they get this, they have access to HRT. The quality and the cost, it's essential that they do it, and they need to do it urgently.
Thank you, everyone, and welcome to this chamber broadcast in the Innovating Healthcare series. And today we're going to concentrate on the menopause. It's October 2022, and it's the National Menopause Month. We've just slightly passed the date of National Menopause Day and World Menopause Day. I just want to introduce my panel first, and then we're going to go through some of the current issues that are affecting this particular area. So could I start with you, Suzanne?
Hi, my name's Suzanne Banks. I'm Clinical Programme Lead for the NHS England National Menopause Programme. I'm not a menopause specialist, but I work with all the clinical reference group.
Okay. And Matthew?
Hi, I'm Matthew Cripps. I'm Director of Behaviour Change in NHS England, and we're with Suzanne heading up the National Menopause Programme.
And Diane?
Good afternoon. I'm Diane Danzebrink. I'm the founder of Menopause Support and the National Make Menopause Matter campaign.
And Melinda, Mel, how are you?
Hi, great, thank you. So I'm Melinda Morgan. I'm Associate Director of HR, Government and Social Value at IQVIA. We are a human data science company, a global provider of healthcare and life science solutions, really helping organisations to gather, analyse and interrogate data to improve patient outcomes. And we're also a clinical research organisation conducting over 20% of all clinical trials in the UK. And we're pivotal in providing clinical trials for COVID-19 as well as running the COVID infection survey. And we are the third largest employer in the life science sector.
Thank you, and that's a great introduction. We are expecting Carolyn Harris, who's the chair of the Menopause All-Party Group, and she will mingle with us fairly soon. She's accomplishing a vote in Parliament at the moment, which is always the inevitability of having a member of Parliament on your panel. So she'll join us as soon as possible. I'm going to start the questioning, however, perhaps with Matthew and Suzanne. It's really good to see both in the media and in the medical press a concentration on the subject of women's health, and particularly around the menopause. But we've also seen issues around cardiovascular health, for instance, and some of the inequalities that in that particular subject. But I'd like to concentrate on the menopause first. Why is it so important that we concentrate on what is inevitably a natural event?
I think it's, partly it's the number of people it impacts on. 51% of the population are women, and all women will go through the menopause. It's partly because although it isn't a medical condition, there are symptoms associated with it, and a significant number of the women who go through perimenopause and menopause do have what we call severe or bothersome symptoms. And so, we're talking 400,000 women every single year enter the perimenopause. So every single year there's that from perimenopause through menopause to postmenopause, there's another 400,000 women. And because of the things that you've just mentioned around, there's unmet need for women across all sorts of clinical need. So there is with menopause, and we don't yet provide an expansive, high quality enough service for all of the women who need it. So yeah, it's not a medical condition, but it is something with symptoms that we can help with. And it's not just about medical. Some of the stuff we're looking at isn't medicalizing. And in fact, we're being very cautious to not over medicalize. There's a lot of stuff that we're planning around self-care and lifestyle and awareness raising and workforce support and so on. So yeah, we're certainly not in the camp of medicalize the menopause, other than when it's an appropriate treatment and the woman decides it following a conversation that balances benefits and risks and so she can choose for herself how she wants to receive our help or not.
So Suzanne, how is NHS England and NHSI going to help with this? How does this programme work at the moment?
Yeah, so we've got several arms on the programme. One of it is looking at population health. So it's about actually what are NICE guidelines telling us, and how do we support frontline staff, so clinicians, not just GPs, but nurses and pharmacists, to follow NICE guidelines, but to follow them in a evidence-based way. So we know obviously at the moment that NICE is reviewing their guidance, so we're working with NICE to review that, because there's some hesitation amongst clinical colleagues about the the report in relation to the association with HRT and breast cancer. So it's about having giving evidence based on NICE, because that's what we want the clinical staff to follow. But it's also about ensuring that there's other professions that can provide support, and it's at that point of contact a woman comes into. So a woman can go to their nurse for a smear. Actually, that might be a trigger for them to have that conversation with them. Or we'll go into a pharmacist, for example, and have problems with sleeplessness, and then that can trigger a conversation. So we've got the optimal pathway aspect, and then the other aspect we've got is around the workforce, so the education, awareness, and how we can retain our workforce, because we know that there's a significant impact on women in the workplace, and what support can we give them. And we know the NHS is a huge employer, and we know that the same impact on nurses and medical staff and other clinical staff, as well as non-clinical staff in the NHS, is affected by the menopause. We know that. There's lots of evidence to show us that. We know the proportion of women is significant, nearly 75% in the NHS. So we know we have to do something about it. So that's another arm of the work that we're doing within the NHS.
Thank you. Diane, we heard Matthew mention about the unmet need there. You work in an organisation that must see quite a lot of that. What's the sort of scale of that need, do you think?
Yeah, we do. I mean, it's pretty huge. Obviously, 3 out of 4 individuals will experience symptoms, and some of those individuals will need to seek help and support. It generally, the first port of call is via their GP, and still very often what we hear is that either they are told that they're too young to be menopausal, that they are still having periods, so they can't commence treatment. They're very often, if it's psychological symptoms that they're experiencing, they're very often, Suzanne mentioned NICE guidance, they're very often incorrectly offered antidepressants as first-line treatment. This is really common. I have to say, I first started speaking out about this back in 2015, so I've sort of been working in this area for about 7 years. There are definitely signs that we are starting to move in the right direction. But what we need is a situation where every individual can access the good quality care and support that not just they need, they deserve, free at the point of need. And I think very much that revolves around a couple of really fundamental issues. And one is ensuring that we have equipped all our doctors and practice nurses with a level of education around menopause, which allows them to help their patients. That's certainly not something that they've had, particularly in the last 20 years since the WHI study. And we also need a situation where women are well informed about perimenopause and menopause before it comes along. And Suzanne mentioned the cervical screening, and I think an ideal opportunity when cervical screening starts at 25, an ideal opportunity is to start to have those conversations, hand out those leaflets at that point, and then to consolidate both of those things with a national public health campaign around menopause.
Thank you. And I'd like to welcome Carolyn Harris now, and thanks for joining us. You chair up the APPG on this. It must be a little bit of an uphill struggle in Parliament with so many other priorities, and it's not exactly a quiet time at the moment. So how has this been received by your colleagues there, and how has it been made a sort of priority? Because I guess you're more interested in the wider impact and the sort of making sure that everyone has access to good care around this.
I'm interested in every aspect of menopause, not least because what Diane talked about was psychological. I thought and lived for 8 years on antidepressants, believing I personally had had a nervous breakdown because of things that had happened in my life. I reasoned with myself that the reason I'd gone on antidepressants was for a completely different reason than being menopausal. And I had many conversations with Diane and many other women, and I was all ready to support women, but I wasn't acknowledging that I was menopausal. It's a little bit like somebody put a light on for me when I realized when I was talking about other women, I was experiencing myself. As for Parliament, I think it's far better received than what people thought it would be. I mean, we've got a debate tomorrow afternoon. It's a 90-minute debate. And I'm surprised at how many people are coming on. And Thursday afternoon is never a good day to have a debate in Parliament because people will want to have left for the weekend. And I'm surprised how many colleagues are either staying or have actually made a point of coming to see me to say, I'm sorry I can't be there tomorrow, but we were there 100%. We had a big event here last week. We had a fantastic turnout. We had a lot of MPs came. And every time we've done anything, we've had a really good turnout, and we've had a good response from across all the parties and men and women. So and I think what is happening, and hands up here, this is not the government's doing, this is people like Diane and people like Positivity and all the other grassroots campaigns, and more latterly the celebrity campaigns. They are the people who brought the attention to this. The government have let it go under the radar. And until I brought my private members bill, they were quite content just for us to talk about it once a year on International Menopause Day. What we've done by talking loud and proud and on social media and on television and all these wonderful avenues that have opened up to us is that now it's become a word which is in mainstream conversations. People are now talking about menopause. I went to the football on Sunday and I had men asking me for selfies because their wife is menopausal and didn't know until she'd heard me speak. And that's the way it's going. It's about giving women the knowledge, giving women the information. But what we need to do is, while we're arming them with that, we've got to make sure that the support and the resource that they need is there to keep them doing and to make them feel wonderful, because once you do feel wonderful, you don't want to lose that. And that's what I see my job is, to be the political mouthpiece, if you like, and make sure that we do keep it on the agenda, and we do and make no mistake, there is not an area of social policy where the menopause does not play a role. You know, and every day I'll have a new email with a new topic, and I can slot it into an area of social policy. I've long said that the Department of Justice, they need to be looking at the menopause, the consequence of it, and how women may end up in the criminal justice system, women in work, women claiming benefits, access to HRT. There is no area of social policy that the menopause does not touch on.
Thank you, Carolyn. We've obviously got a great advocate in Parliament for this, Matthew and colleagues. So that's good to hear. That's good to hear. I was prepped for this by my wife, who told when I said I was going to chair a meeting on the menopause, I sort of got a lecture as to why her behaviours have been slightly bizarre over the years. And she had this validated by all her friends with similar behaviour patterns. So yeah, I'm well aware that we're all getting knowledge of this much more than when I was a GP, when the real dilemmas were around what you prescribe and the safety of prescribing it. I'd like to bring Mel in now, if I could. We're talking here about sort of data and how that could be useful in defining what is safe, and how we conduct clinical trials and getting that democratized so that it's not just the usual people who come into these sort of studies. What's your experience in IQVIA in terms of the menopausal research area?
Well, I suppose from my personal experience, I'm more focused on what we do with wellbeing with our employees. We've got 80,000 employees across the globe, 5,000 in the UK alone, and more than 60% of them are women. So, you know, based on the demographics that we have in the organisation and the huge amount of women in the workplace who have are of menopausal age, and obviously as Diane has well educated our team very well, you know, that isn't, that's the 45s plus. We know that, you know, that there is a huge impact on everybody. And also the fact that we know that, you know, on average, not in IQVIA alone, I have to say, but across the UK, roughly 10% of women will leave the workforce, you know, due to the impact of their symptoms. So it is so key that, you know, we give all the support, and absolutely, with Caroline's point, raise awareness, give people the space and comfort and confidence to talk about menopause, and encourage all our managers to support it and feel comfortable as well. So it's really about making sure in our organisation, educating people to be comfortable and educated and have the resources as well to support them with looking at the menopausal effects.
And Diane, can I bring you in terms of the workplace? There's quite a lot being put forward of late for all employers to look, shall we say, through a new optic as to how to help people through this period of their lives, which must be, you know, a little bit difficult with all the other issues that they have to deal with in employment, etc. Are people coming around to this sort of position now? And maybe Carolyn, you could help with this as well when Diane said.
Yeah, they definitely are. So you know, so certainly over the last, one of the things that we do at Menopause Support is we provide education, training and awareness for businesses and organisations. And we've certainly seen more and more interest in that. And I think the general awareness raising that has been done very much at grassroots level. And then, as Carolyn said, you know, sort of has been consolidated by having MPs who are interested in this, and then those with a public profile who are speaking about their own experiences. I think what we've managed to do is to sort of raise the level of conversation and also to empower women to be able to go to their own employers and say, what are we doing on this? Do we have a menopause policy? I mean, I'll be very frank with you and say, I think the last thing that should come is a policy, because it's all about changing culture. There's no point having a policy if it's going to be a tick box exercise. We need to have the education, the understanding, the awareness, and some kind of framework and structure within the organisation, so that individuals know that when they reach perimenopause, if they are struggling, there's a pathway for them to follow. It's clearly defined, you know, they don't have to go and find it. And yes, great if there's a policy to consolidate that, but it's about changing culture within, not just within an organisation, but within society, essentially. So employers are definitely starting to recognise that this is just good practice, because not only is it right that you're going to support your team as you would with any other issue that they're facing, but from a, you know, sort of from a financial perspective, if they look back historically, they will have lost an awful lot of talent. And as Suzanne rightly said, you know, I think it's 77% of NHS staff are women. The average age is 43. If we don't do something soon in the NHS, it's going to be a disaster. Because I speak to so many nurses, healthcare professionals, etc., who take huge pride in their work, but if their symptoms are cognitive or psychological, and they feel that they might not be able to do the best by the people that they're there to look after, that brings up huge question marks from them, and then makes them step aside, maybe do less hours, maybe leave the organisation altogether. So I think there is a real key issue around recognising and supporting menopause to ensure that we're retaining our talent.
Matthew and Suzanne, I suspect you'll echo those sentiments for the NHS as just been described, and perhaps wider into social care as well, I guess.
Yeah, absolutely. And we're working on a workplace support package. And one of the things that we've picked up recently is we've been talking to industry about what they do, as well as and as a behaviour change person, I know that we've historically designed things for the middle classes, and these things have to be demographically nuanced. So if you're a supermarket, for instance, if your workplace policy is based around the office, well, that's not the majority of your people. And if, you know, it's some simple stuff like if a woman's perimenopausal, are you making sure that she's on the till closest to the staff toilets in case she experiences flooding, or is she right at the far end and has to make it all the way across? And, you know, there's loads of stuff within this. But yeah, absolutely. And we extrapolated that 1 in 10 figure for us, and think that somewhere between 33 to 50,000 women have been lost to the NHS at any point in time. Well, that's the retention programme target that we've been set. I mean, obviously we can't get them all back, but we can avoid the next 33 to 50,000 leaving if we get this right, which we're planning to do.
Good. And Suzanne, anything in addition?
Yeah, I think I'd reiterate actually what Diane's saying. There is something about having a policy, but actually for me, it is about the culture. It's about changing the hearts and minds. Back in 2017, I was the chief nurse at Sherwood Forest, and for me, it was about a cultural change. It was about ensuring that everybody was able to have that conversation, and not just within my organisation. So I did a lot of work with the system at the time. So worked with the local authority, worked with the police, worked with the other acute and mental health trust, and actually started to have that conversation about the menopause. And the reason for that was not just because we were partners in the system, but actually our employees were our local community. And that's the approach we need to take as employers. So it's not just about as an employee, it's about your local community, because by default, by educating your employees as a system, you are educating your community, and that will have a knock-on effect. So we did a lot of work around that. And certainly bearing in mind the audience that this recording will go out, it will be for local authorities. And it's about actually, as a system, you need to start working together. What the policy or the guidance does is just reinforce that, or have something that staff can go to. But actually, if you change the culture, you shouldn't need to go to your policy and guidance. And then the other thing I'd just quickly like to follow on from what Carolyn said around offender health. We know that there are health inequalities in how we support women going through the menopause. We know that the middle-class white woman is the one that advocates needing menopause support, will challenge her primary care healthcare professional, or will access private healthcare. But actually, what about those with English as a second language? What about those who won't say anything because of their cultural issues? What about the transgender? Those in prisons where we know there's anecdotal evidence that actually their sentences increased because of their behaviour at that menopausal period. And what about those that are homeless? We really need to think wider than just those that are in employment. It's our communities and how we support them.
And Carolyn, just to bring you in again here, is tomorrow, it's your debate tomorrow, did you say?
Yeah. And I probably talk about all these things tomorrow, but just to recap on some of the stuff that everybody else have said, Diane is perfectly right. We don't need a policy. And up until, I would say, just before I got my private members bill last year, when we were actually looking for what it was we could get the government to legislate on, and I started seriously looking at policies, and I realised that there is no one-size-fits-all policy. And when I was visiting different workplaces for other issues, and I was talking to the managers, and just coincidentally saying, and how was your menopause policy? They were saying, oh, ours is wonderful. Mostly on an app. It was all singing and all dancing. They'd make a cup of tea if you asked it nicely. But when I said to the girls working on the tills, or the girls on the factory floor, how was the menopause policy working for you? They had no idea they had one. So that's why we don't need a statutory menopause policy. We need a framework where people can actually, the woman will know what best her needs are for the environment she's working in. Any good employer will take into consideration that woman is menopausal and provide her with the resource and the environment to make her experience of work much better. And every employer I've spoke to, especially when you talk to high-end employers like pharmaceutical companies and financial institutions and that kind of organisation, they talk about the competitiveness, about attracting talent. And one of the things they've recognised that in order to attract and retain talent with women, they need to provide the right environment for them to want to stay there or to want to go and work there. And you take it to the other end of the scale when you have women working on the shop floor and in hospitals and in cleaning schools and in factories. They are the women who can't afford not to be working. So it's in the interest of the government to stop them becoming benefit dependent, and it's in the interest of the companies to retain their workforce, because that way then they've got a workforce and the government are not paying hand over fist for sickness benefit or these kinds of things. When I talk to, like I said at the top of this, that I never had a menopause. I now know I had a bloody awful menopause, but I didn't know I was having a menopause, and I thought I had mental health issues. And some would say I still have got mental health issues, but that's insanity rather than mental health issues. And all the girls I was in school, because I was a dinner lady and a barmaid, I became an MP purely by fluke. I didn't go to university till I was well into my 30s, and none of my friends had a menopause, and they've all had some kind of breakdown, whether it's themselves or in their marriage, or they've had some kind of physical pain which would prohibit them from working. And we would have these conversations, but never, ever, ever did anybody say they were menopausal. And I went on Loose Women and talked about being menopausal and going on HRT, and my friends said, well, you were posh having a menopause. Such is the it's not the inability of women to recognise they don't feel well, it's the lack of knowledge about what is causing that not feeling well. And because they are going, like I did, go into a GP with a specific symptom and polarising on that. For me, it was depression and anxiety. I never told my GP about everything else that was going on in my life. So I talked him into giving me antidepressants because I thought that was the answer for me. We never had a discussion about it potentially menopausal. And that's what's happening. Women are going back and forth with different symptoms. Nobody's joining the dots and saying, you are potentially menopausal. Let's just give HRT a try. And then you have the other issue with lower income areas where women are able to get, after a struggle, I would add, to get a prescription. They're not getting body identical HRT. They're getting a different kind of HRT. The body identical is only if you have underlying health conditions. You live in leafy Cheshire and you get body identical immediately. The discrepancy across the country in the quality of the HRT is absolutely startling. But it's always the socially deprived areas which are getting the poor quality. We've got to get this message out there that it costs no more for body identical HRT. They're all roughly the same. We need a national formulary. If we had a national formulary, all HRT would be available right throughout the country. And the other thing I would say, which adds to what Diane was saying about having, I mean, the APPG have recommended a health check. We said 45, but there's no catch-all age. I want to see women being told postnatal, when they have a smear, when they have a coil fitted. But I'd like to see it on the QOFs, because if it was on the QOFs, then GPs may actually be inclined to actually learn what the menopause is, or provide someone in a surgery who knows what the menopause is. Because if we have more people trained to understand the menopause, we'll have less women who will end up in prison, because that does happen, in divorces, committing suicide, giving up work. There's all these negative things happen to women because of the menopause. And it's a huge injustice to women, huge, 51% of the population, and we're not providing the basic resource to give them the right to be normal. We don't want special treatment, we want normality. That's all we're asking for.
Well said. And Mel, I'm just going to ask you, in your sort of work within your company, do you get that sort of variation in, what people have been advised, the type of treatments are being prescribed, and not just the treatments, but things like the investigations, for osteoporosis and issues like that.
Yeah, absolutely, hugely. And I think also very much to that point about the lack of awareness means that people don't realise why they're being prescribed different things a lot of the time and don't know how to go back and ask, for different treatments. So it is massively varied. But I think the other thing is, as we've seen, like when Diane came in the other day for the third time to do training with our teams, we had over 500 people attend. Now, every year it gets bigger, and it's, to Caroline's point, a lot of that is the fact that there's been more media attention, which is brilliant. The fact that more and more people are hearing what's going on. 10% of those were males. We always get a lot of people say, oh, it's a shame we didn't have more. Actually, I don't say that at all. I think it's brilliant, that at least we had 10% of them who are talking then to their friends, their family, and, taking an interest as either individuals or managers. And we actually had people on that call from range of 25 to 67. So, this impacts everybody. And that's why we continue to really strive to try and give our teams more support and resources and knowledge so that absolutely people can have that better idea about the treatments.
That's good to hear. I think one thing I would say, Carolyn, in response to you about the education side of this and GPs, as former GP myself, I've got 60% of newly qualified GPs are now female. There's been a shift, I think, in the last 20 years towards women's health issues in general, and in particular the menopause. So I think there has been a change there.
Yeah,
I think initially it was falling into that category of, well, it's something we need to think about, but we're not quite sure whether we've actually got a strategy within our practices to deal with it. And I guess that's the next bit. But
I talk to a lot of GPs now who at different events, because I've literally done events for every kind of sector, from banking to supermarkets and the building trades, everywhere. And whenever I do speak to a GP, they always say, until they had done the specific menopause training, and somebody presented to them with one symptoms or two with any kind of complications like pre-existing conditions or family history of a certain condition, they would never ever have dreamt of diagnosing HRT. Now that they've done the training and they understand there is certain HRTs which can be given for certain conditions, they are providing a much better service to the women who are coming to them. But it means that even those, until every GP has got the appropriate training, or every cluster has someone with the appropriate training, we're going to have this problem of injustice in care and resource, and that's what we've got to stop. And we know we've had a promise that from this year, I think it's going on the curriculum, and rightly so, but it's 2022. Why have we had to wait till 2022 for something which affects 51% of the population to actually be on a training module for people to understand and learn about? Think of the women who've gone before us who've not had justice. They've not had the opportunity to have normality like we have as HRT warriors.
Okay, well, thank you for that. I'm just going to ask each of you now, I was going to ask you, what the Secretary of State, the new Secretary, when I designed this, I nearly said, and it's of course a woman for you, but of course those days have rapidly passed now, and we have a man as Secretary of State again, but it should be independent of that. But what one thing each of you would you crystallize that will be a good step forward to make sure that this stays on the agenda? I'm going to come to you last, Carolyn, if you don't mind, and then ask others. But we'll start with Diane, perhaps. What one thing would you like to put forward that would be helpful, to keep the menopause on the boil, if you like?
Yeah. So I think going back to something that I said earlier, I think the government providing a national menopause awareness campaign, which would include having menopause adverts on the TV, on the radio, seeing things on trains, on buses, creating a menopause booklet that every individual gets through the door before their 40th birthday. It probably comes with a letter that says something like, you might not want to read this yet, but this is coming down the line. And I think it's also really important for us to recognise that whilst the vast majority will become perimenopausal in their early 40s, we'll also have 1 in 100 under the age of 40 1 in 1,000 under 30 and 1 in 10,000 under 20 who will experience a premature menopause. So we need to also be able to factor that in. And I think talking about it, as Suzanne mentioned earlier, in things like cervical screening, which starts at 25, is a very good way to do that. And of course, it's the very reason why we campaign so hard to include menopause in the RSE curriculum in schools. And I'm thrilled to say that that was added to the RSE curriculum from 2020. So if we have young people learning about it, if we include it in cervical screening from 25, if everybody gets a booklet and we have a public health campaign, that's a really good way to educate and inform people. Then all we need to do is to make sure that they can get the help and support that they need at the time they need it, free to everybody, rather than people being forced into private care, which is what is currently happening.
Okay, thank you. Matthew and then Suzanne.
I think it's maintain and increase the efforts, because there's lots more noise happening now thanks to the campaigners that Carolyn mentioned, and then within Parliament the work that the campaigning MPs did. It's now government, it's in the women's health strategy and so on. But the more effort we can put at this, the better. And that's, I guess, a subcategory of effort is resource, because that leads to the amount of effort you can put into it. And we've got a long way to catch up to create that fairness that, again, Carolyn was talking about. And the more efforts and the more resource we can put towards that, menopause and wider women's health, then the more able we're going to be to close that gap.
Suzanne.
Yeah, I agree. I'd echo actually what Diane and Matthew have just said. I think it is about a population health awareness. So it is about a big campaign. But it's also about considering that campaign and who we're targeting, and not just the middle class white woman who's going to respond to that, how else we target that. And also how we consider those groups that I've mentioned previously. So those that aren't necessarily going to be the ones that either will be supported or will be able to see or to hear some of the campaign that we're doing. And I also think it's about reinforcing the fact Parliament, people like Carolyn have done some fabulous work. It's about actually don't lose that work. We have our first England women's health strategy. We have our first women's health ambassador. Let's not lose that, and let's focus on that, and let's work hand in hand with that individual. And there doesn't need to be a huge time commitment, because the infrastructure's there, the support's there within Parliament with other MPs, but it's about advocating it and supporting it. So I think that's the key thing. And if it was a woman, it'd be even better. But there you go.
Okay, Mel, yours, and then Carolyn, I'll ask you to close. Thank you.
So I definitely think that point about far more awareness raising, continuing to have specialist days, etc., and ambassadors to help it. The biggest difference we saw at work is when we're having these conversations and training, is that people still go on and go, God, I didn't realise that everyone else is feeling the same. And that's scary in a large organisation with so many women, and that they've then set up their own support systems in addition to ours. And that's what employers can really help with. It's not saying do it yourself at all. It's giving them space and time and potentially money to do that alongside our employee-driven focus and activities. But definitely that massive public health campaign, and really encouraging younger people to talk about it. That's a really big point.
And Carolyn, when you come to sum up the debate tomorrow, which I presume you will, what are you going to say?
Oh, I got loads I want to say, and I would agree with
every slightly brief then.
I'd agree with every single thing everybody have said, and that will be in my speech tomorrow in one way, shape or other. But the immediate thing the government has to do is to keep the promise that they made last October, when they refused to give me free HRT, because they said if they give free HRT, there were other medical conditions out there which attract a cost, and if they give it HRT free, they'd end up having people campaigning to make other things free. Coming from a country where we don't pay for medication, I found that a little bit insulting, if I'm honest. But then there was a big fanfare to the fact that they were going to give it a once annual fee of £18 something, and that was going to come in very early in the new year. And the year went on and it went on and it went on, and we still didn't have it. Then we were told we were going to have it in April next year, because the computer system, which allows this prepaid certificate to be issued, originally it was going to take 2 years to do. Then they managed to get it down to a year. But I am hearing some really, really disturbing rumours that it's not going to happen next April. Well, on their head be it, because that has to happen. It has to happen. The cost of living crisis is affecting everyone. Women will not prioritise themselves. There will be women out there who will not pick up HRT because they will be in fear that they're going to run out of money. And we've got to make sure that they get this, they have access to HRT. The quality and the cost, it's essential that they do it, and they need to do it urgently.
Well, thank you very much. And thank you all for your contributions today. I think you've all put this at the top of my agenda to think about, and particularly when I go back and talk to my wife about what we actually achieved today. But I think we have achieved one thing, which was the sort of unanimity around that education piece, about the access to it, about reducing that inequality. And you're quite right, Suzanne, we're look at the composition of this panel. And we need to think about that when we look in the future at how we include other people who may not be in a position to have as much knowledge as we do at the moment, but have still got the problem. So again, thank you all very much.